Hello and welcome to my channel and a new video today on an important topic, which is QT prolongation. This is a critical medical condition that requires rapid recognition and response. If you're new here, I'm Joe Rudy, founder of clinicalpharmacycourses.com, and I've dedicated this channel for this purpose. So if you're interested in clinical pharmacy, make sure to subscribe to the channel and hit the bell button so that you don't miss any of our future videos. Now, let's get started with today's presentation. So this patient was admitted with community-acquired pneumonia and started on azithromycin and ondansetron. On hospital day 2, she reported palpitations and dizziness, which prompted clinical pharmacy evaluation, and we rushed to the patient to see what's going on. The key findings were an ECG showing a prolonged QTC of 520 milliseconds. Labs showed low potassium of 3.1 and a low magnesium of 1.5 milligram per deciliter. Now, these electrolyte abnormalities likely contributed to the prolonged QTC and her symptoms of palpitations and dizziness. We'll need to address the underlying pneumonia, of course, as well as correct the electrolyte imbalances to stabilize such a patient, which could be quite tricky. The QT interval basically represents the total time for the heart's ventricles to depolarize and then repolarize from the start of the Q wave to the end of the T wave. This interval reflects how long it takes for the heart muscle to contract and then recover electrically before the next beat. Since the QT interval varies with heart rate, we usually use the corrected QT, or what we call the QTC, typically calculated using a formula called the Buzzard's formula, but then you'll see it reported on the ECG anyway, so you don't have to do the calculation yourself. A prolonged QTC increases the window of vulnerability of the patient and can lead to serious heart rhythm abnormalities. So why does the QT prolong? This delay, let's talk about QT prolongation first. QT prolongation is primarily caused by medications that block something called the HERG potassium channel, which is responsible for cardiac repolarization. When the HERG channel is blocked, the potassium efflux during repolarization is impaired, delaying the overall repolarization process. So this delay in repolarization is seen as the prolonged QT interval on the ECG. Prolonged QT increases the vulnerable window for the polymorphic ventricular tachycardias, known as the Torsades de Pointes, which can be life-threatening arrhythmias actually. Many common medications, both cardiovascular and non-cardiovascular, can have this off-target effect on the HERG channel and can lead to QT prolongation. Multiple factors can, of course, increase the risk of QT prolongation, and our patient had several of these risk factors. Women are more susceptible to QT prolongation than men, as they tend to have longer baseline QT intervals and a greater sensitivity to QT prolonging drugs. Electrolyte abnormalities is another one, like hypokalemia and hypomagnesemia, and as well as hypocalcemia, can impair the heart's ability to properly repolarize. Taking multiple QT prolonging medications at the same time can, of course, cause some sort of a synergistic additive effect on QT prolongation and is, of course, discouraged. Underlying cardiac conditions such as heart failure, bradycardia, and structural heart disease all together increase the risk of QT prolongation. So there are multiple risk factors that you gotta keep an eye on as it comes to QT prolongation. Now, I just want to highlight some important numbers on this slide. So a normal QTC is usually below 440 milliseconds for men and below 460 milliseconds for women. So up to 460 is fine in women, and up to 440 is fine for men, but not higher than that, because a borderline, this will take us to a borderline prolonged QTC if it's 441 to 469 milliseconds in men, and 461 to 479 milliseconds in women. Now, an actual prolonged QTC that would require you to do something about would be anything 470 milliseconds or higher for men, and 480 milliseconds or higher for women. Now, keep in mind that a QTC of 500 or more is considered a high risk for Torsades de Pointes, and urgent intervention is required for those patients. You can keep in mind, like I kept a clinical pearl there on the right side of the slide. Keep in mind that a QTC of 500 milliseconds or more, or even an increase in QTC by 60 milliseconds or more from baseline, whatever the baseline is, even if it's a normal baseline, that poses risk and is usually associated with higher risk of torsades, even if the baseline of the patient was a normal or borderline QTC. So just keep this in your mind. Anything, if you see anything of a QTC of 500 milliseconds or higher, or a QTC that was normal, and then something happened, and then suddenly it went 60 milliseconds or more higher than the normal, that increases the risk of torsades in those patients. So, of course, significant QT prolongation is a serious condition, like I've been saying throughout this lecture, and it requires immediate action. So, the first thing I would do is to stop all the medications that can prolong QT interval. And in our case, it was erythromycin and ondansetron. Next, I would aggressively replace electrolytes such as the potassium and magnesium in this case to the optimal levels, and I wouldn't really give oral potassium or magnesium because we need quick and immediate actions here. So I would replace electrolytes using IV replacement and take all precautions in place. Continuously monitor the patient on telemetry if that's available at your hospital. Otherwise, you can repeat the ECG after the electrolyte repletion, and usually you need an hour or two after electrolyte repletion to repeat the ECG, and after any medication changes as well. The last thing I would do is thoroughly document the QT prolongation on the patient's chart as an adverse reaction, so that everyone would be aware of it in the future, and probably avoid QT prolonging drugs in the future if possible, or if not possible, keep an eye on the patient, reduce multiple QT prolonging medications if the patient required any of these in the future. Now let's take a look at our patient's medications, see what exactly happened here. The patient basically received a triple hit, as a matter of fact, that led to the QT interval prolongation. And the three medications that have actually led to this case, QT prolongation, were first the azithromycin, which is a macrolide antibiotic that is known to prolong the QT interval. And the other drug was the ondansetron, a serotonin 3 or hydroxytryptamine 3 antagonist that has been shown to block the HERG channel, which can also lead to QT prolongation. And lastly, the hydrochlorothiazide, even though it's not a QT prolonging drug, it might have caused some electrolyte abnormalities or disturbances, such as the hypokalemia and hypomagnesemia, which were evident in this patient. And the electrolyte abnormality could have contributed to the QT prolongation. So it's a triple hit with different mechanisms that caused our patient to end up with, unfortunately, a QT prolongation. Individually, these medications may pose a modest risk, but the combination, when we put them together, created a synergistic and very dangerous situation for the patient. So I don't want you to think that azithromycin is a bad drug or ondansetron is a bad drug. I'm still going to use azithromycin for community-acquired pneumonia. I'm still going to use ondansetron for nausea and vomiting. So they're not bad drugs. It's just the fact that we combine multiple QT prolonging medications in a patient that was vulnerable due to the diuretic and electrolyte abnormalities, and that led to the QT prolonging problem. The key takeaway is that we always need to consider the cumulative QT burden when prescribing multiple medications, even if each one alone does not seem to be a high risk, if you know what I mean. Now, if you're not sure if a medication can prolong QT or not, there is a very good resource that it's my go-to and should be your go-to as well. That is credible.meds.org. That's credible.meds.org, and I think they have an application too that you can download to your phone. This is an evidence-based database that categorizes drugs by their risk of causing QT prolongation and Torsades de Pointes. It's maintained by something called the AZ CERT, a nonprofit organization focused on medication safety. The database has three risk categories: the drugs with known risk, those with the substantial evidence of Torsades de Pointes risk, and then they have the possible risk. Those can cause QT prolongation but lack evidence of Torsades de Pointes. And then there is the conditional risk for those with risk, where the risk is present under specific conditions. So I recommend you to bookmark crediblemeds.org and use it before prescribing or before dispensing medications, or if you're reviewing medications on a daily basis, to make sure that these medications are does not carry the risk of a high risk of QT prolongation, especially in patients with polypharmacy. Those are always high risk patients. So, and you probably do your medication reviews on high risk patients anyway. So, use Credible Meds to help you identify high risk QT prolonging drugs. So just a few key takeaways before we end today's presentation. A QTC of 500 milliseconds or more indicates high risk of Torsades de Pointes, a life-threatening arrhythmia. Immediate intervention is required to prevent this complication. Multiple QT prolonging drugs combined with electrolyte abnormalities can exponentially increase the risk, so we need to think synergistically about all potential contributors. And correcting potassium and magnesium levels is the fastest modifiable intervention that you can do in such patients. Aggressively addressing electrolyte abnormalities should be the top priority right after stopping the insulting medication. Always check credible meds before prescribing common QT prolonging drugs such as antiemetics, antibiotics, or antipsychotics, for example. Understanding the QT risk of medications is crucial. And for more comprehensive resources on QT management, including drug lists or risk scoring protocols, or any additional examples, you can always refer to our course, the clinical pharmacy course, on www.clinicalpharmacycourses.com. We extensively address QT prolonging drugs in our course, and it would be the place to go to if you need more information on this. And that's all I have for you today. Thanks for attending today's lecture. And once again, if you're new on the channel, make sure to subscribe and hit the bell button to not miss any future videos. And of course, if you're interested in learning clinical pharmacy and taking a complete course, visit our website at www.clinicalpharmacycourses.com and sign up for the clinical pharmacy course. Join our database of over 18,000 students that graduated from the course so far. It's an extensive online course with over 44 modules and a didactic part, as well as a practical online residency training, plus a couple of videos to help you with interviews, clinical pharmacy interviews as well. So if this is something you're interested in, please visit our website www.clinicalpharmacycourses.com and learn more about the course. Thank you, and I'll see you in the next video.